what's the name of the game here? So we're trying to take, instead of waiting until cancers are clinically apparent, which often they're stage 3 or 4 when that occurs, we're trying to stage shift them over to stage 1 or 2 where they're more easily treated. Why? Because if you can catch cancer early, the survival rate's 90%. If you catch it late, the survival rate goes down to 20%.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their DNA-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. This is the second half of the two-part series to Dr. Stanford's presentation called Optimizing Healthspan and Longevity by Implementing Personalized Precision Medicine. For this episode, we dive into the science of methylation patterns and how we can use it to detect various cancers and their tissue origins, enabling early intervention for better treatment outcomes, and ultimately paving the way for tailored therapies. Similar to the last episode, there are supporting graphics and diagrams, so we highly recommend watching this episode on our YouTube channel, as this discussion does get pretty technical in various parts of the conversation.
So with cancer, which is about to overtake heart disease as the most common cause of death in American people, there's government recommended screening for cancers. And if you want to include PSA for prostate cancer, it's still a relatively small fraction of the total cancers. 70% of people that die of cancer, these are cancers there's no screening for. So that's a problem. So this is kind of a problem statement, right? So the traditional screening we do now is for these individual cancers: CT scan, mammogram, pap smear, and the like. With the science of today and what Grail's developed and some other companies are doing as well, is liquid biopsies that you actually from a blood sample, you can not only determine whether cancer is present for some of these cancers where they're screening, but a multitude of others. Now, one thing I want to stress is in no way, shape, or form do these liquid biopsies done by anyone or multi-cancer early detection screening. In no way is that a substitute for this screening we talked about. We're talking about mammograms, colonoscopies, CT scan, pap smears. You need to keep doing all that. But we have the ability now to detect some of these other cancers that there is no screening for. And that is a big shift. So how do we do that? What's the science behind it? Are you curious, Taylor?
Yeah, I am curious, and I've seen the term methylation, so I have somewhat of an idea. And I want to refine my idea a little bit more.
Well, I'm going to make you so you can explain how a liquid biopsy works to your girlfriend when you get home tonight.
Okay.
First, you're going to say, are you aware they can detect cancer and 50 different kinds of cancer off of a simple blood test? She's going to go, no. And then you're going to go, hey, you want to know how that's done? Dr. Stanford filled me in today. I'm going to explain it to you. So the first thing to understand is that, and I think this is really fundamental. You ever wonder why you have the same genetic information in a heart cell and it turns into a heart cell, that same chromosomes, the same genes in a neuron, it turns into a neuron? How the heck can that be? And the answer is that in the heart cell, the cardiac muscle cell, the cardiac myocyte, the genes are turned on. So there's 25,000 genes, and they're turned on and off in a choreography, so to speak, to come up with these different tissue types. So in a cardiac muscle cell, you would want all the genes turned on that make this want to be a cardiac muscle cell, and all the genes turned off that would make it want to be one of these other cells. And so in a neuron, you have the neuron genes turned on and the other genes turned off. Kind of a simplification, but it makes the point. So how are these genes turned on and off? I'm going to show you here. So when we talk about methylation of DNA, this way of turning genes on and off that cells have, it's done in a fairly easily understood way. So the genes have a tissue specific pattern, as I alluded to before. So in this case of a colon cell, you would want, you see how there's no methylation, this little thing that looks like a golf ball on a tee. Or I like to think of it as a bowling ball at a parking spot. So if you want to keep someone from parking in your parking spot, go out there and put about 10 bowling balls in there. And I bet no one tries to park in your parking spot. And so this parking spot, when it's open, what comes and lands here is a protein complex that then transcribes this gene. And you can see that this parking spot is open also, so it's going to perhaps transcribe this. This one, there's a bowling ball there. You're not going to want to pull into that parking spot, so that's not going to get transcribed. So here, the RNA polymerase transcription complex is able to park in that spot and transcribe the gene. Remember, we talked about that's how you get to a protein, but here it's going to be blocked. It's for the mechanical engineers out there, we call this an interference fit. It won't fit there. For the biochemistry people, they call it a steric hindrance. So that's kind of a fancy term. But here I just call it the bowling ball in the parking spot. The RNA polymerase isn't going to bind and transcribe that. So these patterns, you remember I said that in addition to sequencing all the letters in these genes and all the letters in the genetic code, well, it's a relatively straightforward thing to also do sequencing and see exactly where these golf balls are. And so if you know that there's golf balls out in front of that gene, then when you sequence it, then you know that that gene is turned off. You with me? So what I want you to appreciate is that for one, there is a certain choreography of a pattern of where these methyl groups are attached that block transcription. And it's different from lung to liver to colon. You see the different patterns?
Yeah, I see the different patterns, but I'm trying to put it together. Because something that you said is it blocks the transcription.
Yeah. So the important thing is when this is called the promoter region in front of the gene, what allows for transcription of this gene so that it's expressed, so that it's turned on, is this parking spot needs to be open for the transcribing complex to be able to bind there. That's kind of missing off this schema here. But a protein complex wants to bind to the DNA here, roll along and transcribe this. I could go all the way up to that basic slide, but from DNA gets transcribed into RNA, not shown here. And that RNA goes out in the cytoplasm and gets made into a colon protein, in this case. So I can tell I've kind of lost you, but just suffice to say that we can sequence. Let me simplify it and say that this gene is the same as this gene, is the same as this gene. What's different among these different tissues is that, in this example, the gene is turned on in most cases here. right? And
Yep.
all
I
these
see it turned
cases.
on.
And in
Yeah.
this case, it's turned off in lung, it's turned on in liver, turned on in colon. And this third row is turned on in lung, turned on in liver, turned off in colon. So what I'm saying is you can sequence and find out which genes are turned on or off by virtue of where the methylation is occurring in a particular tissue at a particular time. And that then is what causes a lung cell to be a lung cell, have the thumbprint, so to speak, of a lung cell, and the liver to have the thumbprint of a liver cell. See how this is a thumbprint?
Yeah. Right.
And this has the thumbprint of a colon cell. We can use simple DNA sequencing techniques to decide what the thumbprint looks like. So
Ah.
methylation is how lung genes get turned on and how liver genes get turned on and lung genes turned off, and how how the colon genes are turned on and the lung and liver genes might be turned off. You understand?
Yeah, so these cell types have, I mean, they're all made up of the same makeup, but then what methylation patterns do is you take a look at the different types of patterns that turn on a specific gene that makes it that identifies it as colon or liver or lung and identifies where and at what time it turns on. But then from a
Exactly.
previous episode, that's where you mentioned that what makes it so difficult with cancer is because it goes in there and it turns on specific patterns to then say, hey, I'm
Thank
actually
you.
this, but I'm actually not this. I'm actually a sneaky little cancer.
Right. So you see over here, the cancer genes. So these cancer genes are, let's say these are tumor suppressor genes, and they're turned on, and tumors are being suppressed in the lung, suppressed in the liver, suppressed in the colon. But look over here. Cancer's a clever dude. When a cell does that malignant transition, it turns off the genes that would help keep cancer from occurring. So if
Mm.
there's something DNA repair enzyme, or some gene that is guiding growth to be controlled, cancer wants to turn that off and have the cell mutate and grow out of control. And the same, like let's say that this gene uh, favors growth and cell division and all that. And so let's say that that's turned on, and that there's methylation here that causes the protein to fold, or it may be to the splice. This gets a little technical. It's not real helpful to show these points of methylation within the gene, but suffice to say, there's other things that cancer does to turn genes on and off to favor cancer growing out of control. And in the same way that we can detect with DNA sequencing where these methylation sites are, we can detect where this cancer signal is.
Ah,
So it turns out that tumor cells growing in your body, especially the aggressive ones, it's growing and dying at the same time. So it sheds these fragments of DNA out into your bloodstream, which they call cell-free DNA. This is circulating tumor cell-free DNA. When we do the blood test, we sequence that DNA and see if it has a cancer pattern. Does that make sense?
I don't think it
The,
makes sense
the,
because
tu-
what got me?
the tumor cells growing out of control, and it's growing and it outgrows its blood supply, or it just like there's constant turnover of cells, although in this case the more of the tumor is being built than is dying. It's outgrowing its blood supply, like I said. We'll say. And when it dies, fragments of the tumor cell, the DNA fragments of the tumor cell, will find its way into your bloodstream. And even healthy cells have cell turnover. We know that, you remember when you were a kid, they say that the cells in your stomach turn over every 7 days or something. They used to make up some number there, but it is true that epithelial cells, like the cells that line your stomach, they're turning over all the time. So, and you've heard that you can do a blood test and tell the gender of the kid and whether or not the kid has, so non-invasive prenatal testing is the same concept. In fact, that's how they found this, is they were perfecting that technique of looking for fetal DNA in the blood and sequencing it and going, hey, wait, this isn't mom. This isn't mom's DNA, must be the baby's. And so they're able to sequence it and look for genetic defects in the baby or chromosomal abnormalities, et cetera. You with me?
Kind of. So backtracking just to make sure that I'm fully understanding this, and this is a little bit newer than, because not familiar with this at all. So tumor cells die, then there's going to be, you can see it.
There's going to be debris, and some of that debris is going to be DNA from the tumor cell, and it's going to wind up in your bloodstream. Now, when they draw your blood, they can detect that tumor DNA.
And so then does that mean then with the methylation patterns that we're looking at, we take that and
so then we sequence that DNA and we can look at see if there's the cancer pattern there.
And
identify the cancer pattern there, then we go, aha, cancer signal detected. Next question is, can we tell what tissue it came from? The answer is yes, because we look for the tissue pattern and we can tell what tissue is likely to be emitting this cancer signal. Make sense?
Right. But in a previous episode, though, didn't you mention that because it metastasizes and can go in different directions, the tissue of origin doesn't necessarily, I mean, it does help, but there's still a, oh my gosh, what's the word? You have to see it with a grain of salt, right? No,
well,
that's totally not
medical. Let me speak to that a little bit.
Okay.
So, I mean, that's an interesting question because, believe it or not, they can tell you with 90%, they can tell you with some degree of certainty, we'll call it 50% certainty, which is really pretty good, that there's cancer present. And then if the cancer is present, they can tell you with 90% certainty what the tissue of origin is. But yeah, I think I know what you're referring to. There's certain tumors like neuroendocrine tumors that may have the same tissue specific pattern, but could be found there's neuroendocrine tissue in a variety of different organs of the body, including like the pancreas or the stomach, et cetera. You with me?
Yeah.
So in that case, you just know that it's a neuroendocrine tumor, but you don't know what organ it's coming from. Or like lymphoma, if there's like a lymphoma present, as you know, it's in a lymph node, could be anywhere in the body, a lymph node anywhere in the body. You with me?
Yeah.
And so getting back to that point, like let's say these are pancreas cells, and this is healthy pancreas cells, and these are pancreatic tumor cells. When it releases this grows and dies and sheds some of the DNA into the bloodstream. We sequence it, we see the cancer signal, and we see that the tissue of origin is likely the pancreas.
All right.
And so I don't know about you, but when I first heard they could do this, it's like science fiction. I mean, it's very Theranos-y. Theranos.
Yeah, I do know Theranos, but it's like real Theranos.
They can't really be doing that, but they really are doing that. And so this is actually, published in peer-reviewed journals. And I did reveal that I'm on their speakers bureau and I educate doctors about this. And by the way, don't feel bad that these are tough slides for you to get. These are meant for teaching physicians and not
lay people.
I like to accept the challenge of teaching these difficult concepts to non-scientists and non-physicians because I don't think they're beyond the grasp of the average person to understand essentially what we're getting at here.
But fascinating though, very fascinating.
As a non-scientist, non-physician, I think you're picking it up here.
Thank you.
So we're, to summarize it, methylation patterns is what makes different, turning genes on and off is what makes them become, instead of all the same, into different types of cells. And we can look at that choreography of these light switches. You ever try to set your garage door opener? They have those pencil switches in there. They call them pencil switches because you kind of lever them up and down with a pencil.
Mm-hmm. I mean, I've only like that. That's for like the receiver signal, then, right? Like, so you can.
Yeah. Also, yeah.
Okay.
And so think of this as pencil switches that turn the genes on and off. And those pencil switches are set in a pattern that. If the pencil switches are set a certain way, it's going to be a lung cell. If they're set another way, it's going to be a liver cell. If they're set a different way, it's going to be a cell in your colon. But if, like the Joker from Batman gets in there and starts flipping the switches, you're going to have a cancer. Your thing's going to turn into cancer, right?
Yeah. And
that cancer, nature loves things that work, and cancer cells, they share their tricks, So this trick of putting methylation and turning these genes on and off is part of what can take a normal cell and make it cancerous. And we can detect those derangements with a simple blood draw and relatively straightforward DNA sequencing. Methylation sequencing is just a very small tweak. If you pre-treat the DNA with something called bisulfite, you can detect these methylation patterns. So it's just that you can not only sequence DNA, but you can sequence these methylation sites. What's the name of the game here? So we're trying to take, instead of waiting until cancers are clinically apparent, which often they're stage 3 or 4 when that occurs, we're trying to stage shift them over to stage 1 or 2 where they're more easily treated. Why? Because if you can catch cancer early, the survival rate's 90%. If you catch it late, the survival rate goes down to 20%. So this is a very key thing. So who gets this test, right? So who do you send to get this $1,000 test? Or girl would like me to say $950 test. And that is, if you're over 50, probably, and you can afford it, because insurance doesn't pay for it quite yet. But I believe insurance will ultimately, probably if the price comes down, probably in 10 years, they'll be paying for stuff like this. But right now they don't. But as a doctor, who do you send for this test? Well, anyone over 50. And certainly people where you have increased concern for cancer. So remember these people. If you look at their clinical risk and their polygenic risk is high and their overall risk is markedly elevated, those are the people that I'm sending for this test.
What's scary though is sometimes those ones because I was thinking about my friend. So my friend in college, he found out accidentally that he had testicular cancer. And by accidentally, he was a martial artist that ended up getting kicked in the nuts and ended up finding out that he had cancer in one of his testicles. And so luckily though, they found it early enough to be able to take that out. But I'm thinking, imagine if he didn't get kicked in the nuts, he could have still had it then and not have known about it until years later. And so for me, I'm just thinking about all those other cases, that you can't necessarily see it, and almost makes me want to get screened even sooner.
Yeah. How long after he got kicked in the nuts did they find his testicular cancer?
That's a good question.
But
I don't know.
It also takes us back to that last podcast. And I asked this question of some doctors the other day. How many times have you heard of someone that sustained like a deep tissue injury to the thigh that then went on to develop a soft tissue sarcoma in that very same spot? So remember we were talking about cancer and, inflammation and oxidative stress and all those things leading to mutations. It's going to make me, you're saying that is going to make me look up and see if there's ever been cases where they suspect that traumatic injury to a testicle has led to testicular cancer. But,
Oh,
so that's that's the first thing that comes to my mind. That maybe it wasn't a coincidence, but one led to the other.
Oh, and it sort of just exacerbated the.
Yeah, so I don't know. You got kicked in the nuts and thing hurt for quite a while, and then something still didn't feel right. And you go back to the doctor and you go, oh, well, it's because you have cancer here. And so then the question is it a coincidence that he got kicked in the nuts, went to the doctor and found, I've been kicked in the nuts 100 times. I've never been to the doctor.
Well, I guess my first question, why would you get kicked in the nuts 100 times? And what were you doing to get
Well, I'll
kicked in
tell
the
you one
nuts?
thing. I used to be the center on my high school football team, and you snap a football up into your groin a few hundred times, your eyes start watering after a while. But anyway, that's for another day. And if you never slipped off the pedals on your bike, that's the other way. That's the other thing.
Okay.
So a euphemism of being kicked in the nuts.
Okay.
There you go. All right. So this talk was really about personalized precision medicine. I'm going to describe a case I have. This picture is not from that case, but by coincidence, my patient was 55 years old, just like the gentleman in this, and he wound up with a coronary CT angiogram that looked like this. But let me set the story up. This guy came to me, very great access to healthcare, could do anything he wants along those lines. Father with heart attack in his 50s or 60s, grandfather, heart attack, 50s or 60s. I'll go heart attack, 50s or 60s. And this guy comes to me because he just wants to be proactive with his health in general, and he wants to make sure he gets the most out of his health span and lifespan, et cetera. And somehow he was referred by another patient of mine that became a big fan of personalized precision medicine. Anywho, I started looking at this guy more carefully. His lipid profile is not favorable. His blood pressure, not well controlled. Had been noted by another doctor in the past, but the patient himself is not a real big fan of medicines. And because he runs 5 miles a day, 6 days a week, or maybe it was 6 miles a day, 5 days a week, and eat a Mediterranean diet and doesn't smoke, etc., he presumed that he was in pretty good shape. But when I did this analysis and looked at his polygenic risk scores and his integrated risk scores for coronary artery disease, they were quite high. I recommended that he go get one of these $600 coronary CT angiograms as shown here in panels A and B and C, and well, really A and B here. C is when this panel C is where they do a little AI on it and they make some fancy pictures, and it's really cool. But the cheaper one you can get for $500 or $600 is this one here. And when he did it, he had a similar looking lesion in a different vessel. So this is actually the right coronary artery. He had it in the left anterior descending, but a similar picture, a fair amount of calcification and some soft, unstable, non-calcified plaque that was relatively high-grade stenosis. It was so bad that the imaging center itself called me and asked me if I wanted them to send him to the ER. And as the patient was asymptomatic and this test was just a screening test, not a diagnostic test, we opted to start him on medications, and he was in a cardiologist's office the next day. He's doing fine. The point being is that with medicine 2.0, the way the current healthcare system works. Until you have that heart attack, nothing happens. There's just not a lot of activity toward being proactive and using the tools of today, including genetics, to stratify someone's risk and say, hey, you may think you're not at risk, but you are at risk. And this guy, even though he's not a fan of taking medicines and maybe not a fan of going to doctors, when you present a person with that evidence that they have increased risk based on not only clinical factors like family history and high cholesterol, but that question. So that question being, grandfather had a heart attack, dad had a heart attack, uncle had a heart attack. Did I inherit that same genetic risk for a heart attack? And the answer in this case for this man was yes. And he sought out this treatment, or excuse me, he didn't seek it out. He went under my direction for this test, and we found something that more than probably saved his life. He more likely than not would have had a very dangerous type of heart attack at some point in the next year or two had we not found this and intervened.
Wow.
We're getting to the end of the talk. So just to summarize, personalized precision medicine, personalized, we understand at a detailed level what the individual genetic risk is, what the individual family history, past medical history, current health status, fold all that together to identify the threats to personal health and longevity. Those areas at increased risk, we target increased attention. The goal of all this is to prevent or delay onset of chronic diseases, thereby improving health span. So we always got to mention Dr. Attia at least once. And so his thesis is by being proactive and paying attention to avoiding these preventable things with things like diet, exercise, medication, supplements, whatever it takes, whatever is evidence-based and indicated, do those things, and you're going to significantly increase your chances of having an extra 10 years of health span, if not lifespan. And personalized medicine in this day and age includes genetic profiling to inform selection of optimal diagnostic tools and therapies. Not everyone needs a coronary CT angio. So you look at those genetics and integrated risk scores to see who needs what test. And the other thing that we have going on is you can use things like, one of the things I didn't mention at all, but I'm sure people will have heard of, you've heard of this concept of biological age as opposed to chronologic age. So these methylation patterns, you see like there's a cancer pattern, there's also an aging pattern. And so they use methylation sequencing to also determine your quote unquote biologic age. And you can use looking at those methylation marks as perhaps being a response to interventions like diet, exercise, and the like. Also, the advanced tools, like things like continuous glucose monitors, max VO2 testing. There's all kinds of tools out there you can use to see how we're doing in our efforts of mitigating these areas of high risk that are threats to your personal health and longevity. Logic tells you that if you delay or even prevent chronic disease and detect it at its earliest possible point, where you can, some cases, reverse and cure, some cases mitigate the effect of the disease, that's what's going to allow you to live better and have a longer health span. And oh, by the way, help reduce this 20% of GDP that we spend on healthcare in this country. 20% of the GDP goes for healthcare. There's no way it should be that high.
Wow.
So right now, the science of medicine is diverging from the practice of medicine. It's outpacing it. So what personalized precision medicine allows you to do is take that Venn diagram and and bring it into union, where the practice and science of medicine are one and the same.
I love it.
There you go.
Thank you so much, Dr. Stanford.
Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.